Official figures show that COVID-19 has infected 5 million people and killed over 300,000 since its discovery as a human disease in mid-January 2020. Major lockdowns have been implemented in over 40% of countries, affecting approximately 80% of the global population. The pandemic has caused a substantial decline in economic activity, which may shrink global GDP by 3% this year, according to last IMF projections. But 5 months later, health systems can breathe. The COVID-19 story has changed substantially, from a bug that has no evidence to spread to humans. And it is like another flu, as the COVID-19 pandemic is real. Social shutdown is the only way to flatten the curve of diffusion of the disease. Now, we have managed it. It is time to exit and to look forward. While most of us have likely followed the same cycle of narrative, from this is nothing to this is very scary, and we are now relieved. The evidence is that Wave 1 outbreak is getting under control, with many but not all countries having active cases peak as early as Feb 17 for China, but just before May for Japan and Asia, in the second end of April for Europe, with Switzerland and Germany. Going back to the new normal is commendable, but management must also monitor disease evolution and the socio-economic burden of the COVID-19 pandemic. 5 uncomfortable truths to cope with. A second wave is likely. We may learn from past influenza like pandemics and the official statistics on the COVID-19 infection rate that the total infected are well below the threshold of herd immunity that allows management. What else can we learn from pandemics and our own simulation post-pandemic? History has demonstrated that pandemic wave 2 frequently follows within 4 to 8 months. This suggests the second wave may hit this year. Simulation can also show what happens if citizens directly distancing each other at 50% of the lockdown success. If the COVID-19 behaves like the common cold, CUB0C43, mild disease, but seasonal and fast decay of immunity, disappearing in 4 to 6 months, or the SARS-CoV-1, more lethal, but with longer immunity, 15 to 3 years, and if we believe cross-immunity within using literature factors like seasonality, which predicts a 20% reproduction rate peak through gap, or 30% virus cross-immunity, the messages are clear. Wave 2 is always possible, notwithstanding preconceptions. Short immunity, like the common cold, and limited cross-immunity can cause faster and greater occurrences than vice versa, possibly larger than waves. Social separation, if too strict, may cause a powerful wave 2 since no build immunity is deployed. However, we require at least 50% contact reduction to control the sickness. Many have suggested we are flying blind regarding vital figures on the pandemic. The official numbers indicate a low infection rate and high death rate for a virus with such a difficult latency in symptoms. Our claim is not that cases are purposely underreported. If they only include hospitalized patients with significant symptoms and systematic testing, those estimates may be sufficient. Not understanding numbers has many risks. First, we may overlook other channels, such as home care, which was a major cause of mortality. The second concern is that hospitalization fatalities are rising from essentially 0 to 20% and possibly 50% in ICUs. Some data make dying seem like a coin flip, which is bad. We must examine folks who critically upgrade from death, free to death liable before hospitalization. However, prevention is difficult without numbers. This difference implies that fatality rates are overestimated and that people may contract the disease more often than reported. At current transmission rates, and since most countries are far from the herd immunity section of infection, a higher contaminated stock increases daily infection flow as the infection figure grows up like a power law. Wave 2 may be risky because bed capacity is fixed or can only be extended linearly. In the COVID-19 pandemic, major cases and deaths are a priority. People are assumed to be fit and proper after recovery. Remember that for every hospital death, 5 others survive, and for every person requiring hospitalization, 5 times more officially and 25 to 50 times more outside the hospital. Over 1/3 of 2,003 SARS hospitalized patients had anxiety and sadness 1 year later. If pneumonia is a sign for COVID-19, hospitalized patients with acute pneumonia are 4 times more likely to develop cardiovascular disease. But those are short-term impacts. Long-term repercussions may exist. Multiple investigations on the in utero reactions of babies born to 1918 pandemic parents show major morbidity consequences 25 to 40 years later, impacting lung, kidney, and other organs, and disrupting productive and social life. According to in utero research, the effects may affect the following generation by 1 to 9% of newborn weight. Health and socioeconomic burdens exist. Average U.S. income and wealth loss during lockdown are over $5,000 and $33,000, respectively. Most countries have added 2% of GDP in fiscal stimulus to repayment facilities. The OECD, using Orbis data, finds that 1/3 of enterprises may run out of liquidity after 3 months of lockdown. The liquidity shortage is enormous and must be addressed. The stimulus may seem too small for the former. This is greater than in 2008, when the G20 spent 1.4% of GDP on stimulus packages, and the US spent more, like China, to bolster the economy. Today, the US and Germany spend close to 10% of their GDP on stimulus. However, some surprises remain. Why do countries with higher COVID-19 damage have less stimulus? Why is fiscal spending not higher than the 2008 crisis? Despite the pandemic's GDP shortfall may vary between 2 to 8% in developed countries for 2020 alone, a larger effect than the 2008 crisis. In fact, assuming consumption and private investment are 70% of GDP, the undiscounted multiplier effect from year 1 to 5 after the 2% spent would be 6%, with recovery of spent by 2022, for a total of 6% of merely the mid-risk of output contraction for COVID-19. The Franco-German team's €500 billion EU recovery plan, backed by the EU budget a few days ago, is bold and would represent a European-wide fiscal policy that could be spent on sustainability-focused infrastructure, new investment in frontier technologies, and more. Finally, the question is whether we stay inclusive, not whether we spend enough to restore. COVID-19's ethnic and socio-economic health impact is clearly negative for poorer socio-economic groups and minorities. Lower socioeconomic groups are more likely to have comorbidities and die from the condition, as well as be unemployed. Or, if employed, they are more exposed due to reduced remote working rates. Inequality from COVID-19 must be addressed next, since it will affect recovery and growth. Finally, the impact of COVID-19 on the state, electoral dynamics, and public economy must be addressed. Many states have voted for exceptional power. First, for imprisonment measures. It may nevertheless be important to see those powers as temporary exceptions, not new rules. Some governments are already tempted to use COVID-19's new power. Elections are solar. The second round of municipal elections in France at COVID-19 may damage election representation. A U.S. study found that counties that voted after Super Tuesday and were then exposed to COVID-19 were 4 percentage points less likely to favor Sanders than Sanders' 2016 vote. This effect is significant and may influence elections due to pandemics like COVID-19. This argument can be extended to the U.S. presidential election if a fresh wave breaks around that time. Here's a key takeaway. It can be scary to hear the truth about COVID-19, but it's important to know what we know. COVID-19 is caused by the SARS-CoV-2 virus, which probably started in bats and may have spread to people through an animal host, possibly at a Wuhan, China, fish market. The exact events of the first broadcast are still being looked into. One uncomfortable truth is that how different countries and areas dealt with the pandemic was very different. Some governments responded quickly and successfully with lockdowns, mask laws, and widespread testing, while others were slower to act or played down the severity of the situation. Another awkward truth is that COVID-19 has a bigger effect on people from disadvantaged groups, like people of color, low-income people, and people who already have health problems. These differences show that people don't have the same access to healthcare, jobs, and social support networks. Spreading false information and conspiracy ideas has also made it harder to control the pandemic and get people to do things like get vaccinated for public health. Some groups are more confused and less trusting because of false information about where the virus came from, how well preventative measures work, and how safe vaccines are. When dealing with the ongoing problems caused by the COVID-19 pandemic, it's important to face these hard facts and learn from them. To stop the pandemic and make society stronger for the future, we need to be open about it, use scientific proof, and work together. Tell us about your thoughts in the comments section below, and like, share, and subscribe to our channel for more. Thanks for watching.